All right, guys. Thank you so much for having me. Can everybody hear me pretty well? Let me pull up the chat box, make sure that I can. All right, awesome. So thank you, Zaire, for that rousing introduction. Thank you so much. And guys, if you need anything herbal, Zaire is definitely your girl. As a West Indian who grew up with granny and mommy and aunties and had access to all that knowledge, it's refreshing to see it here because, you know, typically in society, everything is very medicalized. So it's really refreshing to see that type of information being shared in communities. So I'm Dr. Joanne Michelle Martin. I am a pelvic floor therapist, and like I like to tell everybody, I specialize in everything between the belly button and the knees. I work a lot with pregnant and postpartum women. One of my other passions is working with people with chronic pelvic pain. And sometimes these can be moms that have just had pelvic issues and they're now leading to pain, you know, even beyond, well beyond the pregnancy, or they might have had issues even before. So I'll jump right into my slides here and share those with you. Let's go ahead and there we go. All right, so I'll jump right into that. If you have any questions, I'll pop back into the chat and answer any questions that you guys have. But ultimately, we're talking about the pelvic floor, pregnancy, and childbirth. And this is really for everybody. This is a birth summit. We're having a lot of you in here who support moms, and this is definitely information that you need to know. But this is also really important for the moms. This is also important for the OBs. This is important for the midwives. This is important, you know, for anybody who is going to come into contact with the moms, with the, you know, with even with the dads, because dads need a lot of support. I mean, if moms have all the support they can get, the better it is for them. So whether, like I said, it's any of the birth professionals, the midwives, the doulas, the OBs, or the moms themselves, this information is super important. And a little bit about me before we jump right in. I've been practicing for over 13 years now. I am a clinic owner. I decided to branch out and start working in private practice to really kind of get away from the bureaucracy and treat clients the way that I knew they needed to be treated, because you still had limitations in a lot of the more corporate settings. I worked in the hospital setting, and mother baby, labor and delivery, worked in traditional outpatient settings and so on. I also function as a mentor for other clinicians, either via pelvic health or as a business coach, and as a speaker as well. And I myself am a mom of two and had some pelvic floor issues after the birth of my second kiddo. It's always the second one. First one is such a joy. It's always the second one. So one of my patients told me this, and I love this comment, because when she told me this, it's not that I hadn't heard it before, but when we were having the conversation, it made me listen a lot more. And she said, "I never knew that this existed for women. Why did no one ever tell me about this resource?" Her kids were 17 and 19. She had prolapse. And we started talking about how long she'd been having symptoms. She said, "Well, I've been having symptoms for as long as I've had my kids, you know, as long as I've had them." I said, "And what were your symptoms?" She's like, "Yeah, well, you know, I've leaked in my pants. I've had to wear pads ever since they were born. I just thought this was normal because everyone else said this was normal." And that's usually what you'll find a lot is you'll find that a lot of women's ideas around pregnancy and postpartum stem a lot from community, because in society we have said, "Oh, it's okay to pee your pants," or "It's okay to feel like this," or "You know what, you're not having sex after you've had a baby. Well, you're a mom now, you know, don't you, this is normal." You know, we tell women these things and just kind of leave them to their own devices, and we don't say, "Well, hey, this can help. here's who you need to go to, here's what you need to do, or any of those things, which is a real disservice to a lot of moms. Here's a little bit of research, and there's even more research out there, but I threw this up just to kind of give you perspective. One of the things I usually tell people is if you look to your left and you look to your right, one of the three of you is leaking. You know, one of the three of you is peeing your pants. And that stat is still true to this day. In one in three women will leak after they've had a baby, even beyond a year. 1 in 4 women will report painful sex even a year and a half after their babies have been born. 50% of women have, when they're pregnant, will complain of back pain. And as much as 80% of women will have a combination of the back pain and pelvic girdle pain. 53% of them will have an abdominal separation up to a year after they've had that baby. And we consider that abdominal separation or that diastasis to be positive or present if the separation is greater than about 2 finger widths, or roughly about an inch. 100% of women will have a diastasis in the 3rd trimester. And this fact is not so much to scare women, but more so to educate women, because there are a lot of people out there saying, well, we can cure diastasis and we can do this. And the reality is your body has to stretch to allow for the growth of that baby. If your abdomen doesn't stretch, that baby is not going to be well accommodated. And so your body's natural disposition is going to be to stretch. The tissues are going to stretch to allow for the growth of that baby. And so because of that, there's going to be stretching of that linea alba, that connective tissue. Therefore, when they have had that baby, a lot of these women will still be somewhat stretched. A lot of that also depends on what they're doing, posture, positioning, how they're doing what they're doing on a daily basis, things of that sort. 29, almost 30% of women will have pubic fractures. And one of the stats I didn't put in here was the one on tailbone fractures. And about a good 20 to 30% of women will have some type of tailbone pain postpartum. Childbirth is actually the second leading cause of tailbone injuries after a direct fall on your tailbone. So a lot of women, you know, they're having issues and they're like, well, I've never had a fall on my tailbone, but they've had a delivery. And I've worked with women who have had, you know, unknowing to them, fractures of the tailbone, but they weren't necessarily presenting with pain there, but they were presenting with pelvic floor spasms and things of that sort. So just some interesting facts for you to know and for you to be aware of in how pregnancy can affect the body during and afterwards. There's a research article by Dernia that was written in 2014. And really and truly what it was talking about was, you know, the fact that a lot of the issues that affect a woman during pregnancy can affect them after. You know, a lot of women are already having things like leaking. They're already having incontinence. Some women are having prolapse during their pregnancy. Some women are already having persistent pain. But these things are oftentimes not even being addressed while they're pregnant. A lot of women, you know, when I'm seeing women who don't come to me until they're postpartum, what they're saying is, well, the doctor just told me that was fine, or this person just told me that was fine. You're pregnant, you're going to hurt. And nobody should have to hurt for 9-10 months straight. I mean, because the problem is that these things go from manifesting physically in some people to manifesting psychologically, you know, and then you get a lot of the women who are in pain, and chronic pain is described as pain that's persisted for more than 3 months. So now they're in chronic pain. And for some women, it's really bad, and that can take a toll on their mental health. And then we wonder why we've got all these people postpartum who are having these issues as far as mental health goes. So we need to be mindful. Pregnancy, it's a joyous time, but it can also be a very trying time for a lot of women as well. So we want to be very mindful of that as birth workers, as we're coming into contact with these women. So the biggest thing most people ask is, well, what is this pelvic floor you're always talking about? Like, what is this thing? What does it do? Where is it? You know, why is it important? And the pelvic floor, as you can see from this image right here, it runs from the pubic bone to the tailbone, so front to back, and then it kind of sits between the two sit bones. And it's housed in the pelvic girdle. So your ilium, your ischium, your pubic bones, they house it, but it runs front to back, pubic bone to tailbone. And then from side to side at its widest, from the sit bones. So it's very important because all that area is where we're concerned with for birth and for birth in the baby. When we talk about the inlet and we talk about the outlet and we talk about the changes that are going to occur, well, those changes don't happen independent of the pelvic floor. The pelvic floor really, really has to play a huge role in that, in allowing for a lot of the movements, allowing for a lot of the rotations of the joints, and just helping the baby to be able to come out a lot easier. So there are 4 primary functions. Those are supportive, so it supports the organs, the bladder, the uterus, and the rectum. And it helps to keep them in place and just kind of support them so they're not dropping out, or you're not having any pressures, you're not having any issues with that. It also really as a result of supporting those organs, it helps with their individual function. It helps with control of urine and feces, and that's what we call sphincteric control. At the exits of the urethra and at the exits of the rectum, we have sphincters. And those sphincters, and we have one at the exit of the bladder specifically, but we have those sphincters there, and they're like valves. So imagine turning a faucet on. You turn the faucet on and water runs out. When you're done, you turn the faucet off. And once you turn it off, the water flow stops. And that's very important because we don't want to leak all day, every day. We want to have control, and those sphincters act like the valve. When you're ready to pee, they relax. When you're ready to defecate, they relax and they allow you to do your business. And when you are done, then they go ahead and they engage again so that you can remain dry. They also function to stabilize the pelvis so that the rest of the body can move. So that when your legs are moving when you're walking, or when your trunk is moving when you're doing whatever, maybe bending to pick that baby up or pushing that stroller or whatever have you, that your body is stable. Because if you really look at it, your pelvis is really in the center, more or less, of your body. And so it really helps to add to that stability, and helps to anchor some of those major muscles, those major players, as far as mobility goes. And then last but not least, which comes in really handy, especially postpartum, and just as a matter of female function, the pelvic floor, especially the first layer of the pelvic floor, is a key player in sexual function. So these muscles, the nerves in the area, they help to really address. Hold on, I'm looking at the chat here. Got a few people in the chat asking questions. Okay, hold on, let me see. Oh, you guys can't see the slides. Okay, all right, there we go. Well, I'm glad that we haven't shown anything major. All right, hold on, I'm going to stop the share right here. Thank you guys for letting me know that. I'm going to stop the share for a second, and let's try to pull it up again here.
We could see the slides, we just weren't seeing them move.
Ah, okay. Can you see this one now with the pelvis?
Yes.
Okay, awesome. Well, that's good. Okay. And the fourth major function, like I said, is sexual. So sexual appreciation, being able to enjoy, being able to become aroused, being able to orgasm, being able to sense, penetration, being able to sense and be stimulated, to sense touch, to be stimulated. Those things are super important. And the pelvic floor plays a role in all of those things. Let's see here. There we go. All right. Can you see that new transition?
Yes. Mm-hmm.
Awesome. Awesome. So now we're going to talk about the goal of pelvic PT during your pregnancy. Typically during pregnancy, all of us who function as pelvic floor therapists, we should be, but speaking primarily for myself, we're orthopedic therapists first. So I've been orthopedically trained, every joint, muscle, nerve, fiber, connective tissue in the body, we've been trained to address, assess all those tissues. The pelvic floor is no different. The pelvic girdle is no different. And usually what's happening when women are coming to see me during pregnancy, or what women are mostly complaining of, it's going to be the hip pain. It's going to be the back pain. It's going to be the pelvic pain, the pubic symphysis dysfunction, the SI joint pains. It's going to be neurological pain, because a lot of the time, either as the baby grows and there's more pressure in the pelvic floor, or because of positioning, postures, or other concurrent issues, women are going to have some neurological changes. So now they're coming with numbness, with tingling, with pain, persistent pain, things of that sort. So we help to address those things. Even in the upper body, postural changes, neck pain, shoulder pain, thoracic outlet syndrome is something that I see a lot of women for, carpal tunnel syndrome. So a lot of women will complain of these things during pregnancy. So we work to address those issues, because again, nobody needs to be in pain for 9-10 months. It just doesn't even make any sense, especially if there's help out there to address these issues. The other major thing that we do during pregnancy is that we work with moms to optimize that delivery process. The very first thing that I do with all my clients is I teach them to breathe. The breath is super important. It is probably one of the most important things that women can learn to do appropriately for their delivery process, because for one, it helps to really work on that parasympathetic nervous system. If they really know how to breathe well, then that calming effect is going to be great. If they're just super anxious, they don't know how to breathe, they haven't been coached, then it's, everything can go to hell in a handbasket. The other thing is that the pelvic floor does not work in isolation. So it functions as a part of the core system, the core unit, which is comprised of the pelvic floor, the diaphragm, the deep abdominal muscles, and the spinal muscles, specifically the multifidus, so the very, very deep spinal muscles, because they all kind of act as a corset and as a stabilizing, kind of think of like those belts or braces that people put on. It functions kind of like that. And so as you breathe in and as the diaphragm moves, there is also an associated movement of the pelvic floor that is complementary. So when you take a deep breath in, the diaphragm has to descend. As the diaphragm descends, there's a slight push downward of the organs in the abdomen. They've got to go somewhere because the diaphragm is moving downwards. And to allow and to accommodate for all of this movement, the pelvic floor also gives, so it also elongates. And when you breathe out, then the diaphragm recoils, the organs recoil, the pelvic floor should be recoiling as well. The other major thing with that is we're teaching people to breathe, because it really, really helps when we start talking about coordination, neuromuscular re-education of the pelvic floor muscles, and just the ability to actively and voluntarily control those muscles. So the pelvic floor muscles should be able to lengthen and stretch. They should be able to shorten or contract. And you should be able to do all that voluntarily. And the problem is that oftentimes what a lot of women will hear is, do some Kegels. Well, Kegels, or the typical sense of Kegels, is shorten and contract, shorten and contract, shorten and contract. When you go into a birth, we actually want those muscles to relax and lengthen. So if you've been trained to shorten and contract the whole pregnancy, and nobody's ever taught you how to lengthen, how to relax, how to stretch those muscles, we may have a problem potentially. Especially now if we're talking about the anxious mom who's very upregulated, whose nervous system is like, ah, and, they just have not had that type of support, then we could go into one of those longer labors, one of those more problematic labors, or these are usually the moms that may have a little bit more trauma to the perineum and the pelvic floor. And so again, this is one of the key things that we work on with moms during the pregnancy. The other thing that we touch on is posture. Because we know that as the stomach grows, there are going to be changes. There are going to be changes in her posture, her center of gravity shifts, what her spine looks like. We've got a lot of those moms that as the stomach gets bigger and heavier, they're kind of leaning back and they're waddling a little bit. Well, that's going to affect how you breathe. That's going to affect how the pelvic floor moves. So we start to get into a lot of work on posture. Strengthening to make sure that she's got good strength and mobility of the muscles and the joints in the area. The other reason for strengthening is for a lot of those women with SI joint pain. One of the causes for that is you've got all these changes in the growth of the baby. So you've got changes again in the center of gravity. You've got, changes in the postural alignment. You've got increased laxity of the ligaments because of the relaxin hormone and all the other hormones circulating in the bloodstream. And so a lot of these women are starting to feel somewhat unstable, unsteady, and some of them will describe it to you as that. So, I just don't feel right. It feels really unstable. It feels, and oftentimes, if we can strengthen the muscles around enough, the muscles can act the way that the ligaments should to offer that support in and around the pelvis. So when we talk about strengthening muscles, we're talking about the lumbar muscles. We're talking about, even the core muscles and core awareness. We're talking about the hip muscles, the hamstrings, getting those bigger muscles to help to work together with the pelvis to help stabilize it a little bit more. And again, talking about the pelvic flexibility, just being able to allow those muscles to lengthen as they should. Let's see here. Yes, this PowerPoint will be shared as well. You'll have this, no worries. All right, so other things to consider when women are pregnant, hemorrhoids. Sometimes that could be because of toileting techniques. A lot of women will end up constipated. And partially one of the reasons for this is because of the hormonal influence. Another reason is, depending on how she's feeling, her appetite may or may not be great. If we've got women that have had a lot of morning sickness or have been feeling very nauseated, they're not going to be eating as well, which is what all the information that you would have heard today from Zaire, especially talking about those herbs to support pregnancy. Those are key because we need to get women the right nutrients in their bodies to help. It's, you have to think of the body as a system and not just as simple individual parts. It's a whole system, and one thing can definitely affect something else. So if these women are constipated, if they're not having enough fiber in their diet, if they're not getting the right nutrients, then what's going to happen is they become constipated. They're going to sit on the toilet and they're going to be straining. And as they're straining, they're continuing to cause sometimes little micro tears in and around the tissue, and these hemorrhoids start to form. They become very, very irritated. Incontinence will happen as a result of just weakness of that pelvic floor. Sometimes also because, again, of posturing and positioning. So sometimes it's just very small changes that we can make to address stuff. If that baby is starting to feel heavy later on down in that third trimester, maybe they sneeze, maybe they cough, maybe they laugh, and now they're like, oh my God, I just peed my pants. So they may be dealing with these issues, and we may have to go in there and not only do some strengthening, but we really, again, want to do some motor control and work on those muscles so that they know, okay, when the sneeze is coming on, here's what you need to do. Here's what we need to do to make sure that we're not just constantly strengthening, but that they've got good pelvic muscle mobility. And the vulvar varicosities, oftentimes because of the increased circulation that's happening in the body at this time, sometimes women can get a lot of swelling there. There's not good lymphatic drainage, so they may be complaining, you know, of pain in the crotch, you know, a feeling of swelling, things of those sorts. So we work with women who are having these problems. You know, I also see women who have round ligament pain. I'll see women who are having, again, the SI joint pain, neurological complaints, you know, so belting and bracing when appropriate, a lot of manual therapy and hands-on techniques for these women to help alleviate the symptoms that they're having, address the problems that they're dealing with, and just offer them more comfort, you know, strategies to help them to be more comfortable or to completely alleviate whatever the problem is that's going on. So again, these are some of the things that they may be dealing with. Some women may be dealing with prolapse. Typically doesn't happen with a lot of first-time moms, but you may see moms who have who are in their second or third pregnancy, who might have already had some weakness at the pelvic floor, and now they're picking up a baby. And you know, the doctors are like, well, don't lift anything more than 10 pounds. The reality is, you know, they've got a toddler that they've got to pick up, you know, or they might have, you know, a child under one and they're pregnant with another, and they've got to pick this kiddo up, especially if the kid's not walking or the kid's not moving really well. So it's not a matter of don't do this. What we focus on is what are the things that you need to do to get you through your day? How can we make that better? What can we do to improve your function? What can we do to make these things easier? All right, I had a question there. I'll answer that question in just a second. All right, so when it comes to childbirth, you know, the biggest things for us, and I have supported several births as well as a pelvic floor physical therapist, which is helpful because when I worked with the mom through their pregnancy, you already have that established relationship, that established trust. You know what's going on with their body, you know what their needs are. I had a client whose birth I supported recently. She was seeing me because of really bad back pain. She was having really bad back pain. She was having some SI joint pain, you know, and I said, well, you know, let's address this. We worked on that. The back pain was gone. She would have intermittent soreness, but she kind of knew when she was starting to have that pain. We got her a brace. It was, you know, we got to the point where we decreased her activity, her bouts of activity. You know, if you don't need to be up on your feet for 8 hours, then we're not up on your feet for 8 hours. You know, we started to manage her activity throughout the day, in addition to giving her some things to do, exercises, strengthening. We were doing a lot of manual work. And then I supported her delivery. And when I got into the hospital, they'd had her on her back. And I said, you know, I told the nurse, said, well, if we don't need to do monitoring, because when I got there probably about 30 minutes after she got there, and they had her on the monitor. Baby's fine, mom's fine. Do we need to do constant monitoring? That was, the nurse was like, yes, no, we don't. No, we don't. So I politely asked them if they could remove that. When the doctor came in, I spoke to the doctor because the nurse wanted her on her back. And I said, here's the thing. This is a woman who's had back pain throughout her pregnancy. Being in this position is uncomfortable for her. It's not going to work well. So this is not going to be one of your moms that you want to deliver in this position. Position is super important. They were very amenable, thank God. And so we were able to change her position. This mama delivered her baby in a modified quadruped position. So we had her hands and knees, but we had the head of the bed slightly elevated. So she wasn't fully up in a tall kneel position, but she wasn't all the way down on hands and knees. So we had her up in position of comfort. She had a pillow. That was how she delivered her baby. She delivered him probably an hour and a half after I got there. And so it was a very, very smooth transition. A lot of the times we have to remember, especially as birth professionals, that pregnancy is a snapshot of this person's life. And oftentimes these women may have had issues even before then. You know, they may have had a back surgery, hip surgery, back pain, this problem, that problem. And oftentimes, even though they're doing well and feeling better, because of all the changes that are occurring in the body, these changes sometimes can be enough. The weight gain, the increased pelvic pressure, the postural changes, all these things sometimes can be enough to trigger more or less a relapse of these issues, or cause pain, or cause some of these issues to flare back up. We want to be mindful of that. And so as a result of that, as best as possible, just offering options on positioning can be so key for a lot of these people. I can't tell you the number when I worked in L&D, the number of people that I'd seen who had sickle cell anemia. I had a mom who was 23. She'd already had a total hip replacement. She'd had sickle cell anemia. She had a vascular necrosis of her hip. I don't want her in stirrups with her legs, her hips externally rotated and her legs out like that. I don't. You know, she may do well in the sideline position. Let's get a peanut ball in there. Let's support this mom in another position. But part of that is educating your moms as well on the policies and practices, and helping them to be able to do the research. They've got to do their due diligence as well. But oftentimes you don't know what you don't know. And a lot of people may come to you and tell you they just don't know, or they're just not aware. So even as birth professionals, we have to continue to educate, and we have to continue to seek the best options for our clients, in terms of those medical providers or those facilities that would really support them and give them the birth that they want. So we look at flexibility of the pelvis. How are these joints moving? We know that during labor and delivery, that they have to have, that pelvis has to be able to open to allow that baby to come in. That inlet's gonna open a little bit. We know that, as the baby descends further, we're gonna get changes in the sacrum. So the sacrum is gonna move. We're gonna have some more movement there. We've got to have good mobility of those joints. We've got to have good flexibility of that pelvic floor. Again, it's got to be able to lengthen. It can't be super tight and restricted. I've worked with women who've had chronic pelvic pain that I've seen prior to pregnancy. So they've had issues with penetration, issues with painful sex. Their pelvic floor is just very upregulated. And so these people may be seen all throughout pregnancy because they've got to work on relaxing and lengthening that pelvic floor. If not, they're at higher risk of perineal tears. And not just the grade 1 or grade 2 perineal tears. They're at higher risk of the ripping all the way down to the anus tear. Or they're at risk of, maybe having instrumentation utilized during their delivery, or they're at risk of having a cesarean. And these are things that we need to educate moms on and have them know, so that they know their options. Let's see here. So with a client with vaginismus, and those are some of the ones that have very, very upregulated pelvic floor muscles, not necessarily, they're weak in the sense that they don't, so a strong muscle should be able to shorten, and it should be able to lengthen. If it can't lengthen, it's still going to be considered weak because it's not going through the full excursion of motion that it should. Oftentimes with clients with vaginismus, you're dealing with a couple things. You're dealing with the anxiety component, you're dealing with the pelvic floor component. And so that's going to be, those are things that are going to need to be navigated. So we work a lot on lengthening the pelvic floor muscles. Another client that these oftentimes have to end up getting cesarean is clients that have vestibulitis or vestibulodynia. Which is inflammation of the vestibule, which is the area on the inside of the labia minora. So it's like a little, if you kind of look at Hart's line, for all of you, kind of think of your vulva and look at, inside the labia, and you've got like a little line of demarcation, and the vestibule is kind of on the inside of that. Those women, a lot of the time, especially if these are women who have had severe issues, may have to have a cesarean birth. But these are the conversations that people need to have, because they don't know, and they may be going in expecting to have, vaginal delivery, and everybody's telling them this, and they don't know what they don't know. So they have to be supported appropriately. Those are probably the only women that, if I'm seeing them, that I'm talking to their OB and making sure that we together are educating these women, because the pain, that area is, usually it's because there are too many nerve endings in the area. It's just going to be painful. And so that's especially if they have not had any treatment or anything like that in the past to address that. Let's see. So now we go into after pregnancy. This is where a lot of the issues manifest. So like I said, a lot of the time, the issues that women have during pregnancy will crop back up after pregnancy. The back pain, the hip pain, the pelvic pain. Now they're breastfeeding, so now we've got more neck pain, we've got more shoulder pain. The thoracic outlet syndrome is still a huge possibility because posturally, they're just doing, especially if they're breastfeeding at night, they're just doing whatever they can to get this baby to go to sleep, and so they can get to sleep themselves. Addressing pelvic floor dysfunction, because now, there's going to be some overstretching of the pelvic floor. If they've been well prepared, great. They may be able to bounce back very, very easily from the point of childbirth, very early on in that 4th trimester period. So usually I'll tell women, if you leak within the first week or 2, that's not abnormal. Your body is healing. Your body is trying to kind of get a semblance of itself and just kind of go back to some sense of normalcy. So it's not uncommon. However, you should not be peeing your pants at 6 weeks. You should not be peeing your pants beyond that. You shouldn't, really and truly, you shouldn't be peeing your pants beyond 4 weeks, 2 to 4 weeks after you've had a baby. You shouldn't be having pain with sex, 6 months, 9 months, 12 months, 2 years, 5 years after you've had this baby. But a lot of the time, these issues are never addressed because we've continued to tell women in society, this is normal, you just had a baby, just live with it. And that's what they're hearing. We also want to help them return to functional activity, especially if there was any type of trauma, physically, pelvic floor wise, that might be preventing them from doing anything. For example, pubic symphysis dysfunction. I had a client in the hospital. She became my client after she had the baby, but she had very, very severe pain to the point where when she'd gone to the doctor, they just gave her pain medication and she was pregnant. They just take this Tylenol, ibuprofen, whatever it was. They gave her pain medication while she was pregnant. She went back to the doctor at a subsequent visit and she was saying that it hurts really bad. She wasn't having any relief. They didn't refer her out anywhere. She continued to be in pain to the point where she started using a walker, and then she went into a wheelchair. When she was 37 weeks, she came into the hospital and she told them, you need to take this baby out now because the pain was so severe. She had the baby and I saw her in the hospital. She had the baby and her pain was ridiculous. And the nursing staff, unfortunately, were not very well educated. So going up there, the nurse is thinking that this is just some whiny, malingering individual who does not want to do anything. And I had them do imaging on her. Well, her pubic symphysis was separated 14, it was either 14 or 16 millimeters. Either way, normal is 4 to 7 millimeters. She was double that. This is why she was in pain. Her pelvis was unstable. It was very unsteady. And so went up there, worked with her. She was seen after she was discharged from the hospital. But again, she could not function and she had a young child at home, and thank God that she had community support. But for instance, for those of you living here in Atlanta, we know that this is a very transient city. A majority of women here are here outside of family. And so, them, their spouses, their partners, whomever may be here, but their family is in a different state. So they don't have that level of support that people can just come and stay and, those types of things. So these are also things that we need to consider. Again, common issues that women will deal with after they've had a baby: incontinence, pelvic organ prolapse, painful intercourse, diastasis or the abdominal separation, the persistent joint pain, the back, the hip, the neck, those types of things. Neurological issues, so they may have altered sensation. Either the sensation is decreased or absent, or it's increased, sometimes to the point of persistent pain. or they may just have persistent pelvic pain because those muscles are just so hyper irritated. So I want you guys to do an exercise for me. I want you guys, as you're sitting where you are, sit with your feet nice and flat on the floor. And we're going to find your pelvic floor. And first, I want you to just take a few deep breaths. Just taking a few deep breaths, and we can do it without the towel. What I want you to do is taking your hand like this and putting it under you so that your sit bones rest on just like on the first crease of your fingers, and your fingertips can kind of come up on the inside of your sit bones. And I want you to take a nice deep breath
Sorry, I
in,
didn't see your
and then
hand.
take a deep breath out. And I'll show you here with my pelvic model. So as you're sitting down, your fingertips should come on the inside. And all you're going to do is take a deep breath in and just let everything relax. Just let your pelvic floor relax. Kind of like that feeling you feel when you got to go pee and you just sit on the toilet and you go, ah, and you just let everything out. And then you're going to breathe. So you're taking a big breath in and you're doing that. And now you're going to breathe out. And I want you to try to close your anus. So close the butthole. You're going to take a deep breath in again. Relax everything. And now as you breathe out, I want you to close the vagina. And I want you to kind of notice as you're breathing. So every time you breathe out, you're closing. I want you to notice every time you breathe out what your pelvic floor is. It should be lifting up off of your fingertips. And as you breathe in and as you relax, you should be feeling those tissues come down into your fingertips. So that's what you should be feeling when you do that. And that's a very easy and simple practice that I use with my clients just to kind of help them just to be able to get a sense of where, you know, their pelvic floor is and to be aware. And we do that in a variety of positions and we do it with a variety of cues, but just so that they're aware of where their pelvic floor is. All right, so let me answer a few questions here. Let's see. Outside of Belton for pregnant moms, are there movements that help as well? Yes, so there are movements that will help. It just depends on what the issue is that we're belting them or stabilizing them for. Depending on the severity of their pain, if they can tolerate some strengthening, then we can do that. We may have to do, so it just kind of depends on where they are. We can do strengthening, we can do activity modification as well. So those are the primary things that we're gonna do. I typically don't belt just for the sake of belting and just leave people, because ultimately that just helps with the symptoms, but it's not gonna fix their problem. So as much as possible, I want them to be able to take charge of their situation and be able to, you know, find some comfort in doing what they're doing. Okay. Yep, you will get that exercise technique. Yeah, I'll pull it up here again. Let's pull that up for you. So you'll get this, and this is just one of the many that I have. And I'll give you my contact information. That's what we'll go over in, here now, so that you have that information anytime that you need to get in contact with me. So the other key thing is, when does a mom need pelvic floor PT, especially postpartum, and knowing when to refer. If they've had a cesarean, if they've had forceps or vacuum birth, if they're complaining, if they've had pelvic organ prolapse, and usually the symptoms of that are going to be pressure in the abdomen or pelvis, a feeling of heaviness, feeling like something is about to fall out of the vagina, pain with sex, they may notice anything of that sort, or if you can visibly see something coming out of the vagina. If they've had a history of back or pelvic pain during pregnancy, SI joint, pubic symphysis dysfunction, pelvic girdle pain, hip pain, round ligament pain, if they've had an episiotomy, which most physicians are not doing, but there's still a few out there. If they've had a grade 3 or 4 perineal tear, so they're not just tearing right into the perineum, they're tearing beyond that into the anus. So once they've torn all the way down, those women are at have a higher likelihood of having fecal incontinence, because now that external anal sphincter, that faucet, remember we talked about that valve is not going to be functioning the way that it should to stop feces from coming out. So those women will have fecal incontinence. If they're having persistent pelvic pain, if they had a very long second stage of labor and just were pushing for a very, very long time, that adds to the trauma that they'll have on that pelvic floor. You'll get this information, but I will put this in the comments as well, the bit.ly link for the pelvic floor dysfunction screen. I urge you guys to share this with your clients. You can just have it as something, you know, part of your intake. So when you're seeing women, when they're coming in, have them fill this out. You know, once they've delivered, when you're doing any type of postpartum visits, have them fill it out. Because this will, if they've answered yes to 3 or more of these questions, there's a high likelihood that they're having pelvic floor dysfunction. So this will be a very, very great screen. One of the things that I do is I educate birth professionals, and for those of you here that may be interested, and you will get this, I have a program called Pregnancy and Postpartum for the Birth Professional. Right now for this group, it's typically $197, and for this group, you can have that for one payment of $147.75 or 3 of $59.25, and the links are there. But you will, again, you will have those links as well, and I'll post them in the chat. But you will have those as well if you are interested in just taking a deep dive beyond the information that I've just presented here. There's probably 20 something videos, but then there's also a list of resources that you can utilize with your clients. So much information in there that's really helpful for you, for your clients, and just elevating your practice and your ability to help your clients. In lieu of everything that's going on right now with coronavirus and people being, you know, not being able to go into places and stuff like that, you may have clients who are at home on bed rest. You may have clients who are just at home. I also offer online sessions. So if anyone, you have a client, you have a question or a concern, they have a question or a concern, I do online consultations and sessions. So if they need that, you can utilize this link, or it can also be found at www.onlinepelvictherapy.com. And here is all my information for you. But you, like I said, you'll have this stuff, and I will type this up in the chat box as well, so that you guys will have access to this. So let me go ahead and answer some questions here, because I see it blinking. Okay, so when receiving pelvic floor PT, what is the average length of therapy? How long does it usually take for results with closing a diastasis? That is very person dependent. I would love to tell you that I am like the cookie cutter people that are on all the websites and stuff that will guarantee stuff, half of which they cannot come through on. But each person is different. And so on average, I would say I see most of my clients for 4 to 6 sessions on average. Now, there are clients that I've had with a diastasis that's been relatively simple, and I've seen them for the 4 to 6 sessions. I've had clients with a diastasis that I've seen longer than that. I've seen people for 12 sessions. I've seen people beyond that, and the ones that I'm seeing beyond that, usually it's because it's not just the diastasis. There's other stuff going on. I had a mom that I saw when I saw her for about 8 sessions. And that was over the course of probably 3 months. I saw her once a week for a month, and then we went to every other week after that. And when I started working with her, her diastasis was 7 finger widths. So, you know, you take all the fingers on one hand and, you know, 7 finger widths apart. And she had twins. She delivered twins. So needless to say, but she also had tremendous pelvic floor weakness. Poor coordination. She'd had quite a lot going on. So oftentimes for a person like that, it's not going to be a 1 or 2, session. It's going to take a lot longer than that.
Can I ask a question?
Sure.
What are some strategies we can use, like even for ourselves who are not pregnant, to strengthen our pelvic floor?
The key, I would say, is how do you know that your pelvic floor needs to be strengthened? And that's usually what I will ask most of my clients coming in, because everybody's like, I need to strengthen, I need to strengthen, I need to strengthen. So we look at symptoms first. What are your symptoms, and what are your concerns? The biggest thing is, do you have A, pelvic mobility, and B, do you have control? So can you actively engage those muscles? Can you find those muscles? Can you engage those muscles? Can you relax those muscles? Because you can't strengthen, and you're not going to strengthen effectively if you can't find the muscles and if you don't have good voluntary control. It's like trying to do a bicep curl. You go into the gym and you're like, I want to get strong. You see somebody who is benching and doing pull-ups, and they're doing all this stuff, and you kind of want to jump to all that stuff, and you go pick up like a 2-pound dumbbell and you're dying, right? So we kind of have to figure out where each person is at and then go from there. So oftentimes that's the first thing I would tell them. Look at what your control is. Do you have good voluntary control? If you do, then yeah, we can go right into some strengthening exercises. And then it's going to be looking at endurance of the muscles as well as some control. But if you don't, it's trying to get you to the point where you can work on voluntarily engaging and relaxing these muscles first.
Okay.
How intimate is pelvic floor? So the thing with pelvic floor therapy is it really just depends on what the person is coming in for. For my clients with a diastasis, I don't necessarily do any internal assessment. So as a doctor of physical therapy, as a pelvic floor therapist, I am trained to do internal assessments on women, to be able to identify the muscles, where the nerves are, all these different things. And there are a lot of people that come in that I don't do an internal assessment on, and typically I won't do it on everybody on the first visit anyway. I want for people to be comfortable. There are going to be people that are going to be coming to me for certain issues that may not immediately warrant it. And it really has a lot to do with the individual. So I do see, being here in Georgia, I do have a very conservative population. So I do have a lot of women who may be coming to me, and they're just, and you can tell, like they know, they've read up, I've explained external assessment, internal assessments, and they're like, and you can tell. And it's like, listen, at the end of the day, this is your body. When you are ready to move forward with an internal assessment, or when I feel that it is most warranted, we can do that. There's still a lot that we can do externally in manual techniques. There's still some manual assessment that I can do to assess the muscles and their function externally. And so we do that, and we'll do as much as we can. For my clients who, whether they're pregnant or not, may have issues with vaginismus or dyspareunia and have issues with penetration, those aren't going to be people that you're going to be doing internal assessments on early on. I need them to be able to relax. There are a lot of things that we need to work through first before they can even tolerate any type of penetration or anything of that sort. So it really depends on the person and what they've got going on. Can you support a woman at 74 with a prolapsed uterus? You can, and it just depends on, again, it depends on what she's got going on. So, 74 is not, all 74s aren't gonna look the same. You can have the 74-year-old woman who is active, who is vibrant, who is healthy, and you can have the 74-year-old woman who has every comorbidity under the sun. Those are two totally different people. And so it would just really depend on what they've got going on and what their needs are. So it may be that you can have somebody who will have full resolution of their prolapse symptoms from pelvic floor therapy. It may be someone who, I've had a older adult who was active. She used to like to jog. or speed walk really, outdoors. And she would find that after she got to 2 miles or so, that's when she would start to feel that heaviness and pressure. She didn't have any issues otherwise, at home with transfers or sneezing, coughing, laughing. She didn't have any other issues otherwise than with her activity. And so, speaking with her gynecologist, we got her pessary support so that she could utilize that when she was doing her activity. And I do that with a lot of my younger athletes as well, while we continue to work on strengthening and things of that sort. Because in her normal day-to-day function, there were no issues. That's, like I said, that's going to look a little bit different for the woman who may have other issues going on, especially if there's neurological compromise. So if there's some nerve issues in there, then, there's going to be, we're going to have to somewhat take a little bit of a different direction. Let's see. Any other questions? Is this deal for the list of resources only for it? This is available. So I'm going to go ahead and pull up the links right now. This is available for, let me put it in here. Oh gosh, I can't even see on my phone. This is available through, this is for this group, and it's available through Wednesday. So that's one. Oh, wait, hold on. Yeah, I'll put the information in there. bit.ly. So that's the first one right there. The other one is the 3-pay, which is like I said, it's $59.25. I cannot multitask. There we go. So those are the two options right there. The other thing is if you guys, I'll give you my link to, and you can share this one with your clients. If they need to schedule a virtual session, they can do that. My website is jmmhealthsolutions.com. So you guys have that as well. And I will get the presentation to Tracy so that she can distribute it to each.
We don't see it.
Oh wait, you can't see what? Because I'm not typing to everyone. Oh my goodness. Wait, hold on. There we go. There we go. Can you see that now? Should be there. Awesome, awesome, awesome. And then if you guys need to call me, I also offer calls for professionals, complimentary calls as well. If you need me, if there's a client that you need to support, anything like that, I'm happy to help. If you have questions or concerns, then definitely let me know. You can always go ahead and reach me, schedule a link for a call, or through my website. All my information is on the website anyway, contact number, address. My office is, for those of you here in Atlanta, my office is in downtown Duluth. And outside of coronavirus, I typically will also see clients in their homes. So I see a lot of my pregnant and postpartum clients in their homes as well, because I do understand that a lot of them have little ones, and sometimes that's just tough to navigate, childcare, this, that, and that. So even at this time, I'm still doing home visits for my moms who are, want a home visit, and then I'm doing the online calls for those who want those as well. And do you guys have any other questions? All right, well, thank you so much for the opportunity to be here and to share this information with you. Yes, let me go ahead and get you the link for the slides. I might have to sign out of If you guys give me, I'll let Tracy go ahead and talk to wrap up, and I'll put that in here for you guys. I just have to shorten the link because it's a really long link.
Thank you, Juan.